Yeah, this is an observational retrospective study. We included actually the 31 patients that we included in the expanded access program for cenobamate. And this pool of data was already included in the study published in May 2023 in Epilepsia Open, which is a real-life study that includes 170 patients from the expanded access program in Spain. So what we noticed is that from our sample, so the 31 patients from our center showed higher efficacy and lower levels of co-medication use. So we wanted to look at that because we thought maybe we optimized the treatment with cenobamate better and wanted to look at the details. Yeah, so what we saw is that our efficacy results were very much in the line of the clinical trials. There were very good efficacy results. The response rate for more than 50% was 67%. And actually, after 1 year of treatment, the seizure freedom rate was 25%. So these are very, very good results. And these were actually very, very refractory patients. These are the patients that didn't have option to take any other medication. They had tried already a mean of 15 anti-seizure drugs and had a mean of around 60 seizures per month. So these were very, very refractory focal epilepsy patients. And yeah, they responded very well. We had patients on epilepsy surgery lists that are out of the epilepsy surgery option because these were difficult surgeries, and they are now seizure free, and they are they have much better quality of life now. The main 2 points we found out is that we reached this high efficacy data by reaching high dosages of cenobamate. So the mean dose at 3 months was 207, something like that. But after 12 months, we kept on titrating cenobamate up, and the mean dose was 327, something like that. So these are high dosages of cenobamate. Cenobamate has already shown from its clinical trials that it has a dose-dependent effect. So the main point is you have to try to get to high dosages of cenobamate. And how we did that? So we did that by reducing co-medication. So from very early on, still already from 50 milligrams of cenobamate, you have to start proactively reducing the sodium channel blocker and the GABAergic, because we have noticed that the pharmacodynamic interactions with sodium channel blockers and GABAergics matter much more in terms of adverse effects than the pharmacokinetic interactions cenobamate has. And if you don't reduce them proactively, at least 25% by the second month, you are not able to titrate up cenobamate in many cases. So that's what we found. Yeah, actually, the adverse effects and the safety profile of cenobamate is very predictable. So the adverse effects are all CNS related. They are somnolence, dizziness, ataxia, headache. They are some of the sodium channel blockers and the GABAergic side effects. So another important point is that the safety profile of cenobamate depends on how you combine it. So if you combine cenobamate with sodium channel blockers or GABAergic drugs, these pharmacodynamic interactions will hamper you on the up titration of cenobamate. So you have to reduce the sodium channel blocker and the GABAergic, and then actually the adverse effects we got were much better than in the clinical trials and much better than in the real life study published in Spain, because after 12 months we had somnolence in around 27% of patients, and this was mild somnolence. This was completely tolerable. But for ataxia, for dizziness, for diplopia, for any other side effect, we did not have much, actually 5-10%, and this is much lower than in the published data so far. So the key for cenobamate is to reduce the other medications. The safety profile actually, when you take cenobamate alone, is very good, but the interactions are the ones that bring these adverse effects. We had 4 patients in this sample that had already experienced skin rashes due to sodium channel blockers, and none of them experienced any skin rash. So for us, it's quite safe. Also concerning the skin rash concern that rose during the clinical trials. In our 31 patient sample, we had 7 discontinuations. So this discontinuation profile is quite similar to the published ones. In the clinical trials, cenobamate has proved to be better than other drugs with discontinuations. Patients tend to persist on cenobamate probably due to the good safety profile and to the efficacy profile. 7 patients discontinued, which means that 78% of our sample continued on cenobamate after 1 year. And discontinuations were due to lack of efficacy in 4 of them. 3 of them experienced seizure worsening, and this is probably due to the fact that they were this kind of secondary generalized, symptomatic generalized patients, I don't know how you want to call them, these Lennox-Gastaut-like patients, and they in our experience do not respond so well to cenobamate, but the normal focal refractory patients respond very well, and the other discontinuation was due to a hospitalization, and then they changed the drugs there. Yeah, I think the reduction of complication is always a goal for us. So we are always looking for leaving the patient with monotherapy if we can, or at least with a rational therapy, polytherapy, in which drugs are not at very high dosages. And with cenobamate, the thinking is that we are able to reduce complication because we have a very efficacious response. And on the other side, we need to do it. Because if we do not reduce the complications, then these side effects related to the pharmacodynamic interactions with sodium channel blockers and GABAergics will appear. So we are very much motivated to reduce the sodium channel blockers and the GABAergics from the beginning. We are very confident because we have not experienced any seizure worsening due to that. We are confident on the efficacy of cenobamate, and already from 50 milligrams on, we reduce the sodium channel blocker and the GABAergic because we want to, the patient wants, and we need to. For us, we tend to use carbamazepine a lot in focal refractory patients. So most of them were on carbamazepine, and but also some of them were on lacosamide, for example, and we reduced both very early on. So at the 3rd month, the carbamazepine dose was around half of the initial dose, and after 3 months, the lacosamide dose was half. And after 12 months, lacosamide was almost in every patient suspended or left at around 20% of the initial dose, so very low dosages. And carbamazepine was reduced to 30% of the initial dose. So yeah, these are the drugs that we reduced most rapidly, and also benzodiazepines because of the interactions with the GABAergic effect. So we usually use clobazam also allowed in these patients, and we reduced it also from the beginning, similarly to what we do with the sodium channel blockers. There's a lot of evidence already about that. We know that reducing co-medication improves the quality of life of patients, and also improves adherence because it's easier for them to stay on the medication and not forget any take. And yeah, for us, what it was easy to do. We actually also got information about the global impression of change of the patients. So we used this global impression of change scale, and we had around 65% of patients that experienced an improvement in their quality of life. 45% approximately experienced actually a very, very good improvement. So all our results concerning quality of life are very good. And we had worsening already only in 17% of our patients, and this was due to discontinuation. So all the patients that had a bad outcome concerning this global impression of improvement discontinued cenobamate actually. In our experience, the quality of life has improved dramatically for these patients. These were patients that had more than 60 seizures a month. They were totally dependent. They could not work. They could not study. So for them, it's life-changing. For us, it's another whole different story. These were patients that were coming to us every month, maybe every 2 months. They kept on having seizures. They had traumatic brain injury sometimes. They had accidents on the street, and they were very much anxious about that and depressed sometimes. And now they're able to go out to practice sports, even to go back to the labor market to start to work again. So for them, it's like they are able to do what they wanted to do all the time, and they could not due to epilepsy. So they are not cured, of course. This is not epilepsy surgery, but it's close to that. It's much better than any other drugs in our experience. As you know, cenobamate has been approved to be used with the failure already of 2 well-indicated drugs, but we should stick to that indication. I don't think we should wait more because there's no reason to. This is a very safe drug. This is a very effective drug, and every patient would like to have the most effective drug and be seizure-free as soon as possible. So that's what we're striving to do, and we are starting to use it already with the failure of 2 medications. Maybe less than 1 year of duration of epilepsy, you can already think about that, because usually you try an SV2A and sodium channel blocker, they keep on having seizures, then think of cenobamate, and that's what we do.